This is just the beginning.
Hello, and welcome to The Care Divide, an Axios virtual event. I'm Sam Baker, the healthcare editor at Axios, coming to you from Washington, D.C. I'd like to thank the Institute for Gene Therapies for making this conversation possible today as we discuss the affordability and accessibility of basic healthcare services and advanced treatments. And I'd like to welcome our audiences on Facebook, YouTube, Twitter, LinkedIn, and on Axios.com. If you are on Twitter, please join the conversation with hashtag Axios Events and follow @Axios. Over the next 30 minutes, we will unpack racial inequities in healthcare, where they come from and how to solve them. Our first guest in that conversation is Representative Terri Sewell, who represents Alabama's 7th Congressional District and is joining us today also from Washington, D.C. Congresswoman, thank you so much for being with us.
Absolutely.
So I think the coronavirus pandemic has opened a lot of people's eyes to some of the deep and severe racial disparities within the American healthcare system. But obviously, as you well know, that is not a new problem. It's something that the U.S. has been grappling with or failing to grapple with for a lot of years in a lot of ways. I know that well before the pandemic, you had advocated for and secured some funding for research, I believe some of it at the NIH, some elsewhere, into some of the root causes of this problem. And so I wonder, with the sort of intensity we see now and that groundwork, do you feel like we are close or getting closer to having, for lack of a better word, an action plan to actually start making progress and tackling this?
You know, I think that you are absolutely right that this COVID-19 pandemic has only exacerbated the health disparities and frankly, the racial health disparities that continue to plague our nation's healthcare system. In my home state of Alabama, communities of color often have poor access to care, preventive services, and healthcare insurance coverage. We have not expanded Medicaid, for example, and we've seen closures of our rural hospitals, which have disproportionately affected people of color, as well as rural citizens of Alabama. You know, as a result, Alabama still often has higher rates of chronic diseases, higher mortality, and poor health outcomes in Caucasians. You know, the bottom line for me is that every American deserves the highest quality health care available, and that universal health care coverage must be a central legislative priority. No American, regardless of race or socioeconomic status, should be denied access to quality, affordable health care. I believe because of this pandemic has really laid bare the systemic disinvestments that we've had over the years in trying to close these health disparities. So I believe that the American Rescue Plan, for example, giving extension of the Affordable Care Act, we're currently in an enrollment period right now. That's great. It also increases the amount of subsidies that working Americans will get in order to get better health care insurance. And it also includes a provision that I've been fighting for, and that is to extend incentives for states that have not expanded Medicaid, like Alabama, a 5% boost, encouraging them to do so now over the next 2 years.
A lot of this conversation tends to center around basic care or things that already exist. Health insurance, access to high quality hospitals, chronic disease management, that sort of thing. But there's also, of course, a pressing need to ensure that people of color and historically underrepresented communities are included in clinical trials and generally are part of the research into the next generation of care and of medical treatment. Do you see that as a separate problem, or is it all the same?
Well, you know, I think that it is a problem that just exacerbates the core issue, which is lack of access to quality care, and the fact that you don't have preventative services, you can't actually get the benefit of being able to treat some of these issues early on, which just adds to the cost. So I believe that all of this is wrapped up in the same problem. We as Americans and this amazing country that we have, no one should go without access to quality, affordable health care. And I think that it's not just a privilege for the few, it should be a right for everyone. And so You will see me continuously fight for universal access and also to try to increase the amount of money that goes for clinical trials. I think that we've seen with this vaccination an early on hesitation in communities of color getting this vaccine. And frankly, they were very legitimate concerns, given, for example, in Alabama, the Tuskegee experiment and the like, that there is a fear that government is experimenting with people of color. But what we've also seen is that once people get the right information, we do an aggressive outreach campaign. We've seen communities of color step up and receive these vaccinations. Likewise, I think it's about providing the resources to really do the outreach on clinical trials so that we can close the gap on clinical trials. I think that the first step for anything is acknowledging the disparities that exist, and then we can actually tackle the problems.
And how much of this would need to come from the federal government? How much needs to come from states? You mentioned Medicaid, which is sort of a major driver to tackle some of these problems, but a state that doesn't want to expand Medicaid just doesn't expand Medicaid. So how much is federal? How much needs to come from the states? How much is sort of bigger cultural change that needs to happen? How much of it needs to come from within the healthcare system?
Well, I think that we have to tackle it on all fronts. This is such a systemic problem. The fact that we have disinvested in communities of color when it comes to education, healthcare, the socioeconomic system. It's not just in healthcare, these disparities exist. And so we need a multi-pronged approach. The reality is that Medicare, Medicaid, the lion's share of the costs come from the federal government. But the states have to prioritize the resources that they have to leverage those resources to address this problem. An example, for example, the problem with Black maternity mortality, the fact that irrespective of socioeconomic backgrounds, Black mothers are dying in childbirth at higher rates than white moms, irrespective of whether or not they have the resources or access to health care. Their outcomes are different. And we have to tackle that problem. This is something that is solvable if both states, federal, and local, stakeholders actually prioritize this problem. So, look, hope springs eternal. I am forever the optimist, but I think that it's my job to make sure that the federal resources are there in order to address these disparities that are health disparities, but that are disproportionate in people of color. So they're really racial disparities. And so this is a part of the systemic racism, the institutional racism that exists in America. We have to deal with that. I'm very grateful to Chairman Neal. I'm on the Ways and Means Committee, and he has put together a task force. He calls it the Racial Initiative, the Racial Equity Initiative, and I am co-chair of that. And I'm honored that we're going to be viewing public policy that is being promulgated out of the Ways and Means Committee in healthcare and tax and trade through a racial equity lens. That is the first step, acknowledging that there is a historic, institutional, systemic problem that only can be addressed if we acknowledge it and try to tackle it on all fronts.
So obviously it's only been, or it's been less than 100 days of the Biden administration, but Joe Biden did come into office unusually for a new president, focused on public health. Not just that, but unusually focused on a public health crisis that has really laid bare, as you said, a lot of these health disparities. What more do you need to see from this administration on this front?
Well, first of all, I am very proud of this administration really honoring the promise that the Biden-Harris team said that they would do when they were on the campaign trail. We cannot move forward this economy and move forward in any way until we deal with the public health crisis at hand, which is this pandemic. I believe that the $1.9 trillion American Rescue Plan does just that. It provides that additional relief on top of the CARES Act to really make sure that that Americans as individuals can get through this pandemic, but that businesses and that local governments can get through this pandemic. And it also provides additional resources so that we can address the historic disparities that exist in healthcare, and so we can improve the outcomes for all Americans. And so I'm pleased with this administration so far, and I know that the American Jobs Plan will also be a huge effort in recovery from this pandemic. And so I think that obviously the proof is in the pudding, and I think that it's important that we effectively implement the various resources and deploy them effectively and efficiently. And so I look forward to continuing to partner with this administration that has really shown that they want to keep healthcare top of priority and top of mind for all Americans, and they really want to deliver on that front. And so I am very pleased thus far and look forward to rolling up my sleeves and continuing to be a partner with this administration and with my state to try to address the growing need for more access to quality health care. If Alabama, along with the 12 states, the other 11 states that have not expanded Medicaid, would just use this incentive, 5% boost that's in the American Rescue Plan, they would actually be able to save a lot of money and also increase access. In Alabama alone, 300,000 more Alabamians would be on the Medicaid roll and would have access to affordable care through the Medicaid expansion. So I think that the federal government can continue to give those sweeteners, but until the states realize that this is about people, not about politics, and put politics aside, they can even call it whatever they want to call it. If you want to call it Governor Ivey's care in the state of Alabama, I'm willing to do that. The point is to have 300,000 Alabamians more on the rolls would be a big help. And so I think the bottom line for health disparities is that we need to see this as a multi-pronged approach and make sure that the states, as well as the federal government, as well as localities, really try to leverage those resources in order to close that gap. That's the only way that we're going to see lower costs in the system if we have more preventive services and better outcomes.
Fair enough. Well, obviously there is no shortage of work to be done on this, and it's a big enough topic we could go on for days, or I guess for years, as this conversation has been going on. But I know that you're very busy, so I will let you get back to work, as it were. But Congresswoman, thank you so much for taking the time to be with us today. I really appreciate your insight.
Well, I appreciate this, and I think that it's important that we realize that we have to use every tool in the arsenal in order to really close the gap in health disparities. I continue to work on that with telehealth opportunities for rural Americans and all Americans. But I think it's really important that we realize that the healthcare should be a right and not a privilege for the few.
Great. Well, thank you again. Really appreciate your time. And up next, we have a View from the Top segment with my colleague, Dominique Taylor, the Chief People Officer at Axios.
Now joining us from St. Croix in the U.S. Virgin Islands, Chair of the Institute for Gene Therapies, Dr. Donna Christensen. Welcome.
Thank you. It's good to be with you.
Dr. Christensen, the pandemic has really brought a spotlight on the myriad racial inequities that exist in healthcare. And a lot of people are now aware of things like healthcare affordability, but they may not be aware that racial divides exist in areas like access to new and experimental treatments. Can you explain what some of the challenges are that communities of color face in gaining access to these treatments?
Yes, well, you go back to all of the social and economic determinants of health that present the challenges for access to any kind of healthcare. But our people often get to care late. And in the case of gene therapies, the earlier you can screen, the better. So when you get there late, it's often after a lot of disability has set in, morbidity has set in. So we have issues with getting screened at an early stage when the treatments that are coming online can do the most good. We also have issues with research. We're not very much involved in clinical trials. That's something that I've worked on for years, even with the National Medical Association before I went to Congress, but we're not present in a lot of research trials. And that's important as well. The other issue is access. Even when you have access, sometimes your algorithms don't value our lives to determine the quality effectiveness of the cost effectiveness of medications. There's something called quality that is used to determine whether this person's life is worth using this medication. And it works against African Americans. It's worked against people with sickle cell.
And you've worked for a long time, as you just mentioned, to get us all to a better place in terms of health equity. So what are some of the improvements that you have seen that could make a difference, and where could they be applied here?
Well, unfortunately, we still have a long way to go, but I thought long and hard about this. And there are a couple of things that have shown what can help. Just a small increase in a minimum wage, for example, has been shown to reduce low birth weight births and therefore reduce neonatal deaths. When you move an individual out of a high poverty, low resource area to a place that has a much better environment, we see their health improve. So we know that with improvement in the social and economic determinants of health, which is where the work has to be done, not for all kinds of access, but that doesn't get as much to gene therapy as that's across the board.
Yeah, a very holistic approach needed there. But in terms of your work at the Institute for Gene Therapies, what is most promising or what is most exciting right now?
Well, the exciting part is that we're working to make sure that everyone who needs the gene therapy, this transformative treatment, is able to get it. And that's going to involve developing innovative ways of paying for these services because they are expensive, but not compared to someone who has to take medication every day for a lifetime and add in all of the hospitalizations and other entities that increase their costs. So working with Congress, working with the private sector, working with our patient advocates, our goal is to make sure that these transformative therapies are available for everyone. And that's going to involve working with Congress, especially on the Medicaid issue when we're talking about people who don't normally have access. But CMS has been very open to having discussions, and Congress is poised to do something about health disparities. And this is an important area for them to focus on, because as you develop new therapies, that are expensive, it's even harder for people who are of low income and people who are minorities, people of color, to access them.
And you mentioned Congress is poised. What would your recommendation be to Congress as to what they could do in order to address these health disparities?
Well, I think one, for the gene therapies specifically, I think that they need to help us to with the Medicaid payments to ensure that Medicaid develops an innovative payment plan to ensure that these therapies can reach the individuals who need them and reach them early when it's important to begin to start these therapies. They can reauthorize the Early Screening Act and expand on that act and expand funding for that act so that most of our rare diseases are genetic and most of those are in children. So the earlier that we can screen those children and get the therapy to them, we can reduce a lot of morbidity and disability and even death.
Early intervention matters and makes a difference here as well as everywhere else. Thank you so much for your insights and your perspectives. Thank you for what you have done and what you are doing.
Thank you.
And thank you to the Institute for Gene Therapies for sponsoring this event. And now back to my colleague, Sam Baker.
Thanks, Dominique. Our final guest today is Dr. Magdala Chery, an internal medicine physician and the founder of Not Just a Black Body. She's joining us from Boston. Dr. Chery, welcome.
Hi, Sam. Thank you for having me.
Thank you for joining us. So when we talk about racial disparities in health, that is a big subject in every way. The consequences are big. It's very far-reaching, affects obviously millions of people, and a whole lot of societal problems flow into it. So I'm just curious, as you try to take that on and try to make some progress, where do you start?
Yeah, it's a big problem. I have to take a deep breath before I can even answer your question, but you're absolutely right. It is a big problem. And I think this is why this moment in healthcare is so big. I know it may be daunting to think about how do we talk about racial inequities? How do we actually start thinking about solutions? But we are on the backdrop of a pandemic that disproportionately impacted communities of color. And I speak from experience as a doctor and a Black woman who's lost both of her parents to the virus in a matter of weeks. And in that experience, I saw firsthand what it looked like when I took my father to a safety net hospital and they didn't have resources. And to be in the emergency room and hearing people speak so many different languages and no translators. To hear someone say, I think we're running out of oxygen. We can't tolerate if we have more people coming in, as well as hearing friends outside of my experience sharing that their family members got turned away. They weren't believed in their symptoms that looked and sounded like COVID and ended up dying at home. So if we want to think about where we can start with this pandemic that's still not over and start to really take a step back, listen to the stories of what has happened in this pandemic and start to center the communities and the voices that experience this firsthand and really amplify their voice. Because as they share their stories, they're also going to be revealing solutions and things that we need to consider.
So I'm curious what you sort of make of when we talk about this problem. I think there's a growing awareness sort of in the policy world that our healthcare disparities are to some extent and in some part, a product of disparities in housing, employment, which pulls in education, all these social determinants of health that are also important. You obviously don't want to turn your back on a complete diagnosis of a systemic problem. On the other hand, it obviously can't be the case that all these health problems have nothing to do with the healthcare system discreetly and narrowly. So I'm curious how you sort of how you balance that, or how you sort of break this off into more manageable pieces without sort of solving all forms of systemic racism at once.
Yeah, that's often the remark that gets made by a lot of people when they're not sure where to start or they feel like there's so many moving parts. So I will say one of my best terms to use when we're talking about social determinants of health was Daniel Dawes uses this term, political determinants of health is probably the best way to put it, because it lets you see the structures, the political structures, the institutional structures that really are holding the strings and pulling the strings in these communities. And I think just sometimes we have to just understand the language a little bit better to really know where the problems are starting. Another way to think about it is just think about the healthcare experience. Often when people say their interaction with the healthcare system, someone's thinking about your one-on-one with a doctor or a nurse. But really, think about everything it takes for a person to come in. So if I feel sick, I have to call out of work. Depending on what job, do I have sick days? Am I given time to take out of work? Okay, so then there's questions about what's happening in the work environment that's allowing essential workers an opportunity to be able to come in to take a day off and not lose income. All right, there's one car in a family and my wife has the car now. So now how am I going to actually get to the doctors and I'm really, really sick? So is there transportation? Am I taking public transportation? Am I having to call an Uber? What are we having structures where now if a person actually makes an appointment, the office actually sends a car to pick them up, right? Okay, so they got there. I got there and I don't know how to read the information you provided me. You're using big medical terminology. It's not making sense. What support are we providing to make sure that the information is translated in a way that our community understands it? Okay, so I got to the office and now I only have 15 minutes. And I can't even begin to tell you where to start. And I'm not going to share with you that I only had one car. I'm not going to share with you that, my employer didn't give me a day off. So even in that small descriptive interaction, I'm highlighting the many touch points by which in these communities of color, in the Black, brown communities, these are where the resources are lacking. These are the things that we need to start to talk about when we talk about our interaction with the healthcare system. It's not just the care we provide, it's the whole dynamic of the interaction. How did they get to us? When they got to us, do they feel safe to tell us what's going on in their life and with their health? And how do we actually make sure they're understanding what's happening as we describe their health conditions and how we prioritize their needs? So it's really understanding the whole dynamic of what it means to seek out care in our healthcare system. And then in those dynamics, step back and say, where do we need to improve those touch points?
And so if you were advising, say, a hospital administrator or a physician, someone in the industry who maybe would say, I have no control over whether this person's employer will give them a day off or their transportation situation, but once they come through the door, where would you tell that practitioner to start? Or maybe not once they come through the door, how should that practitioner operate their practice differently, or what should they do proactively to sort of be part of the solution here?
Oh man, that's a heavy question. So if we're going to talk about right at the door, I guess that where we can really say start is how trustworthy is your institution? Okay, you're telling me that fixing what's going on outside is a long-term game, right? And we know that it's going to take years, it's going to take policy, it's going to take a lot of interactions to know what's happening. But the question that I have for you is, when a patient steps through your door, do they feel safe? Do they feel like they can trust that their needs will be heard? That when they tell you they're in pain, when they tell you something doesn't feel right in my body, when they tell you I need help, I need you to help me feel better, that you're actually listening. So what are you doing within your institution to establish trust? So patients actually feel okay coming to the hospital. Another way to look at this is a lot of times in marginalized communities, many of those safety net hospitals, those community centers, people don't want to go there because they know that they are lacking resources. They know they feel like they're othered. So how do we improve those resources that are right there where people are going to come to you and say, I trust that I'm getting the best care here. I trust that I'm actually being heard. And I trust that they want my well-being to be, they want to help me be better and be healthy. And I think that's something at your institution, CEOs, people in senior leadership can decide, how do we build trust? And how do we actually amplify the voices of leaders who look like the community and put them in senior leadership? Because quite often, those voices, those individuals are surrogates of trust from the community that will also help to convey that message.
And so I think you've had some personal experience here with your families sort of building trust in important healthcare interventions. What works? What's the blueprint to build that trust?
Great. I think one tangible example I can give is, let's talk about the vaccine, and we can talk about vaccine hesitancy. When we talk about that, we have to understand how we frame it. I think people have a right to be hesitant, but the way we're going to get past that hesitancy is to have conversations where people feel safe. And an example of that is my sister was extremely hesitant, especially after losing my mother and our mother and our father, about getting the vaccine. She's like, why should I now trust that this is actually going to work, especially when we've allowed so many people to die? And it took multiple conversations, but eventually she was able to get the vaccine, and she actually got the Johnson & Johnson vaccine. Becoming full circle, 4 weeks after she received the vaccine, where she's now in that immunity window, her roommate got really sick, and her roommate had COVID. And thankfully, because she's vaccinated, she didn't have symptoms. Now imagine if I didn't have that conversation. Imagine if I didn't hear what she was concerned about to really get on board with getting vaccinated. That's what we need, trusted conversation so people feel heard and we can actually move forward together.
Okay. Dr. Chery, thank you so much for taking the time and sharing your wisdom and your expertise. Really appreciate it.
Thank you for having me, Sam.
And thank all of you for joining us this afternoon for another conversation that has made everyone smarter, faster. And thanks again to our sponsor, the Institute for Gene Therapies, for making this event possible. I hope you will keep up with all of Axios' healthcare reporting, which you can do by signing up for Vitals. That is our daily healthcare newsletter. You can subscribe to Vitals and all of Axios' newsletters at axios.com/newsletters or in the Axios app. Thank you again for joining us today, and we will see you on axios.com.